Welcome to ICU Primary Prepcast. My name is Swapnil and I'm joined by Dr. Mike Clifford from Melbourne.
Before we commit, I think it's important that we congratulate you because I think you received an honour in the Australian Honours this year. You're now an AO for your contribution to education in the intensive care community. Well done. Very well deserved. And I think everyone out there listening to this podcast should just stand up and give you a little clap, and then we'll sit down again and we'll get on with the teaching. But you're a
Thanks,
legend.
Mike. That was honored by the ANZICS, not the AO. But no, really appreciate it. And I think thanks to you and Maddie for helping in this journey. It wouldn't have been possible without you guys. Well done.
Absolute pleasure. Always.
Thank you. So today's snippet is about the breathing. And I'm recently doing meditation and I'm learning about this polyvagal theory, which is quite fascinating. So Mike, the question is about the control of breathing. So how much is expected from the candidate and what should they write in this SAQ?
Okay. All right. So control of breathing tends to cause a lot more pain and torment for the candidates than it needs to. This is yet another one of those sensor, control or effector responses that we talk about, whether we're talking about hormones, whether we're talking about reflexes. And if you think about the control of breathing, it's all about the control of CO2. Okay. So if your CO2 goes up because your minute volume goes down, that has to be sensed and responded to with an increase in minute ventilation. Similarly, if you've increased your production of CO2 because of, say, exercise, then your body has to sense that and increase the minute ventilation to remove that CO2 back down to normal. And that will preserve body pH and preserve your CO2 and oxygen carriage around the bloodstream. So that's what it's all about. Now, if you start at that point, it's actually reasonably easy to identify what the sensors and the effectors are. The detail and the confusion is often in the control area, in the medulla, and we'll come to that. And I would suggest to people that you don't get too caught up in the major detail because all of the textbooks vary slightly and none of them are simple. And that's because it's very, very complex, okay? And the physiology is often defined in rat studies or mice studies, and they keep finding new neurons that do new things to the nature of the breathing and the nature of firing of neurons. So don't worry about it too much. Just go back, try and get most of your marks in the sensing and the affecting, okay? So if you think about the sensors, there are central and peripheral chemoreceptors. The central chemoreceptors are located near the ventrolateral surface of the medulla in the vicinity of the 9th and 10th cranial nerve. And the CO2 will cross the blood-brain barrier, combine with water, dissociate into hydrogen ion, and it's the increase in hydrogen ion concentration of the CSF which stimulates perhaps pH-sensitive potassium channels, and that will increase the stimulus to the central pattern generator, resulting in increased ventilation. Okay, so the brain tastes the blood or tastes the pH of the blood, detects an increasing acidity, and then suddenly becomes stimulated. Hypoxia is also sensed centrally, and then you get an increase in respiratory response, but it largely augments the CO2 response. Okay, we'll come back to that. And you can imagine how there's a curve of increasing CO2 with increasing minute ventilation, and that curve's in CAM, it's in West, it's in Ganong, and any change in CO2 leading to a change in minute ventilation will be augmented by a lower oxygen level. So that makes sense. If you're hypercapnic and hypoxic, you'll breathe even faster than if you're just hypercapnic, okay? Now, there's also peripheral chemoreceptors, and these are located in the carotid bodies at the bifurcation of the common carotid arteries, and they're also in the aortic bodies of the aortic arch, and they contain these glomus cells, and again, these are probably O2 sensing potassium channels, and they respond to a decrease in arterial oxygen with a steep increase in firing, particularly when the PO2 is less than about 50 to 60 millimeters of mercury, and that's okay because we remember that number because that's the ICU number of hypoxemia, and the response to arterial PCO2 is also present, but probably less important than the central receptors. But again, the carotid bodies respond to a fall in arterial pH, increased temperature, or even low blood pressure, and augment a very rapid increase in CO2 elimination and minute ventilation. And again, you can imagine here where you would have a partial pressure of oxygen versus ventilation curve, and it too will be augmented by an increasing CO2. And this is the same way of saying exactly the same information. If you're hypoxic and you're hypercapnic, you'll breathe even faster than if you're just hypoxic alone. Now, there are other receptors, okay? There are pulmonary stretch receptors that occur in the walls of the airways. There are irritant receptors that lie between the epithelial cells and respond to chemical stimuli. There are so-called J receptors that respond to edema in the alveolar walls and capillaries, and that may be one of the mechanisms for dyspnea in the setting of congestive cardiac failure. And there are bronchial C fibers that respond to chemicals in the airways. And there's lots of other receptors in the airway, in the nose. If you know a couple of those extra receptors, that's a bonus. The money is in the central medullary receptors for CO2 or hydrogen ion, the carotid body receptors for oxygen, which so the brainstem is tasting the blood for acid, and the glomus cells in the carotid bodies are tasting the blood for oxygen, if you like. And then you've got these other receptors generated throughout the lung, which are tasting the air for chemical stimuli and for stretch and various other things. Okay, so all of these sensors are now going to travel via the cranial nerves via 5, 7, 9, and 10. Because remember, cranial nerve 7 is our cranial nerve that has taste in it, and it went out, and so does cranial nerve 9, so to the nucleus tractus solitarius. So all of these taste fibers that are tasting blood are now going to go up to the brainstem. And that's where we have a central controller. Now, try and keep this fairly simple, okay? The neurons that generate rhythm are all in the medulla, okay? There are dorsal and ventral respiratory groups, and they contain nerves that fire in phase with respiration, right? And that's motor output. The dorsal respiratory group are predominantly sensory, okay, and primarily inspiratory neurons. The ventral respiratory group are primarily motor, but they have both inspiratory and expiratory neurons. So you can read about Bottinger and pre-Bottinger complexes and various other things. The bottom line is that the pre-Bottinger groups of that dorsal respiratory group are important for inspiratory timing. The ventral respiratory group, or the Bottinger group, if you like, are expiratory force timing. And both of those combine in the presence of an elevated CO2 to increase your minute ventilation. So they will increase the rate of firing. They will increase the number of elements of firing, so that they increase the ramp of the muscles in inspiration. So as soon as they detect an increase in acidity or an increase in CO2 partial pressure, largely acidity, they respond by massively increasing their firing and their rate of firing and the number of the neurons that are firing. So you get this massive outpouring down to your inspiratory muscles. Makes perfect sense, okay? There are other small areas in there like the apneustic center and the pneumotaxic center, and they act to sort of put a brake on some of those neurons so that you're not breathing crazily or you don't overstretch your lungs and damage yourself. So there are these fine controls within the brainstem that are oscillating back and forward, and it's all within that same area of the medulla. There are lots of books to read about this. CAM is not bad. Bullep and bay pepper, or boron and bay pepper, is pretty good too. Go to none and just read about the control at the level of the brainstem. But if you keep it relatively simple, and remember the aim is to respond to an increasing CO2 with an increasing minute ventilation, and then you can imagine to yourself, well, how do you increase your minute ventilation? You increase both your tidal volume and your rate. So I've got to have neurons firing more frequently, more powerfully, and I've got to increase my inspiratory muscles. And now we've come to the effector side of the description, and that is your innervation of your muscles of your laryngopharynx, so cranial nerves 9 and 10, your diaphragm, which is 3, 4, 5, keeps the diaphragm alive. That's the phrenic nerve, and your external and internal intercostal muscles, but also your abdominal muscles and accessory muscles of inspiration, so-called, and even your little alar nasal muscles that open your nostrils. So if you think about a person who's in severe respiratory distress, what are they doing? They're breathing really big and deeply and fast with their diaphragm. They're taking these massive breaths. You can see their pectoral muscles expanding. Their intercostal muscles are going for it like the clappers. Their nasal flaring. They're opening their mouth really widely and opening up their throat. All of those muscles are being innervated by all of the cranial nerve efferents and the upper spinal nerve efferents to those muscles and the intercostals of their intercostal level. And similarly, the expiratory muscles will be activated as well when you've got increased minute ventilation, because you've got to get the air in as fast as you can, but then you've got to get it back out as fast as you can. So that's why the groups of effector neurons co-located. because an increase in inspiration to increase minute ventilation has to be associated with an increase in expiration. It's a little bit like the heart, which has an increase in systole when you increase your adrenaline, which is also associated with an increase in function of diastole. Okay, so diastole gets quicker because systole is getting quicker. And if you think about it, breathing, the inspiration is like the systolic effect of breathing. So our neurons have to get faster and more frequent so that our muscles can contract more quickly and more powerfully. And we have inspiratory muscles that drag the air in, and then we activate expiratory muscles to push the air out. And many of our expiratory muscles are really only activated when we are stressed and we're really trying to ramp up our minute ventilation. And that's pretty much it. Sensing components, brainstem, peripheral, and then sort of tiny modulators within the lungs, largely to limit the excesses that we have. Central controllers within the medulla, dorsal group, ventral group, sensory and motor components, and then effectors, inspiratory and expiratory motor elements throughout the head and neck, the diaphragm, and the intercostal and pectoral muscles. And that's it for the control of breathing. But the primary element is maintaining normal CO2 and oxygen to a degree, but any increase in CO2 due to decreased minute ventilation or increased production leads to a change through all of that system to increase minute ventilation. And if you can remember what you're trying to achieve, you can almost make it up from first principles. The cherry on the cake for this question and what you need to go away and read about now is that little bit of integration within the brainstem. So good luck with that.
Thanks, Mike. I think that's really important. And I think thanks for simplifying the answer, because a lot of candidates struggle with this question. And I think if you can incorporate a diagram in your answer, that will make the answer better.
Yeah. So particularly graphs of the response of minute ventilation to O2 and CO2, and then just adding in another curve that parallels those curves, showing what would happen if you've got the combination of a low oxygen with a high CO2 or a high CO2 with a low oxygen. That will just add to your answer. Those graphs, they're in CAM.
Yeah, thanks, Mike. So that's the end of today's snippet. We'll be back with another snippet in another week's time. Till then, goodbye.
See you later, everybody. Thank you, and well done again, Swapnil.